Okay, so let's open it up for questions. I think we can start here in the room, and maybe I can just go ahead, and while you're thinking about questions to ask, we'll start up here. So my first question for Bryn. You mentioned the problem of weight stigma and discrimination, but our audience is mostly scientists and clinicians and not policymakers. So what can they do as scientists and clinicians to address weight stigma and discrimination today?
Great, thank you for the opportunity to answer that question. First thing that comes to mind is assess weight stigma and discrimination. It could be in your studies directly measuring it. It could be as a clinician talking with people about what their experience is with these issues. Second thing, OAC, Obesity Action Coalition, did a phenomenal national campaign, an anti-stigma campaign. Amplify it. This needs to get out wider. A third thing that people can do is provide testimony or expert guidance and for the efforts to try to ban weight discrimination. As scientists, we're the ones, and clinicians, we're the ones who can bring the evidence to bear on policy decisions so that they're informed by evidence. That's us. We have to bring that. Policymakers don't have the evidence unless we bring it to them. That's a crucial piece of making change, to ban weight discrimination anywhere that we can in this country. Thank you.
Very good. So moving on to Craig, given that your background sort of straddles both clinical and public health side, and particularly your context of bringing this perspective of public health surveillance, what would your thoughts be on how to measure success for obesity treatments?
I'll just say right away, I don't have the answers. I unfortunately don't have the definitive answer for those things, but I have been thinking about it quite a lot. It would be helpful if you could pull up the, like right in the middle of the presentation around where I'm showing the healthy people goals for hypertension, and kind of go through that just to see what can we pull from those definitions that are relevant for obesity. And it looks like slide 9. But for hypertension, first of all, the definition of hypertension is defined not only by, go up, I think 3 slides up from that.
This one?
One more. Up. Thank you. Yeah,
okay.
So even the definition of hypertension for surveillance purposes is defined not only just by the physical exam measurement of blood pressure, but also takes into account the fact that somebody might not have elevated blood pressure because it's being treated. And so I think, that we do see that. I think that is a relevant concept for obesity as well. I mean, first of all, it's obvious that when the definitions from the clinical guidelines get translated down to public health surveillance, a lot is lost in translation. And so, because surveillance, you're looking at the whole population, and it's not like we can have a physician do a full physical exam and have longitudinal follow-up and all of that. So there's necessarily some differences between what's the definitions in the guidelines and how we define a metric for public health surveillance. So, but for increased control of high blood pressure in adults, there's a set cut point, 130/80, that they're used to say that this is control, and that's consistent with the clinical guidelines. So I think that's a little less relevant for obesity. Can you go to the next slide, please? So for hypercholesterolemia, so they look at, this is interesting because they look at the mean total blood cholesterol level. So that would be more like looking at the mean BMI in a population, which I think can be instructive. It gives you it gives you one view of what's happening. It doesn't give you the whole view, but it's one view. Increasing cholesterol treatment in adults. So this is just saying, recognizing that for people who are eligible for treatment, that they're being treated. That's also relevant for obesity, but I think it could be challenging to implement. Could you go to the next one? For diabetes, reducing the number of diabetes cases diagnosed per year. I think that one's kind of interesting because it's not, you're looking at prevalence, it's looking at the number of cases diagnosed. And in some ways that's good because it recognizes that diabetes is a long-term disease. And so having the number of cases diagnosed each year is a more proximal measure of changes in the population, whereas the changes in prevalence we would see over the longer term. I think diagnosis is really challenging for obesity because there's so much stigma around it, for one thing. And I know that even in the obesity medicine clinic where I worked, I never said I'm diagnosing you with obesity, and I never even used the word obesity in the clinical setting. And so I think that could be a challenge to capture in a surveillance setting. And then we have reduced the proportion of adults with diabetes who have an A1C value above 9%. And this one's interesting because the clinical guidelines give you kind of an anchor of 7% as a target, but with a recognition that could be higher or lower depending on the individual. And so for the surveillance definition, we get a little bit of wiggle room there. But it's a metric that's telling you something important about the population overall. Now, this might not be meaningful for someone who has a target of 6.5, say that's their individual target. This definition is not meaningful for that person, but on a population level, I think it does give you valuable information. And yeah, I think that's and just the concept that I was mentioning before about the person who isn't in a weight reduced state. I think a lot of people, they think of diabetes as something that you either have or that you don't have. If you have it, then you lose weight, and then you don't have it anymore if your BMI is below 30. But I would say that, but that's really different than how we look at these other conditions, because even if these conditions are controlled, we don't say, well, I don't have hypertension anymore because I'm taking this pill and now I don't have it. So I think that concept is also relevant for obesity, and it represents a different way of thinking about the person who is successfully treated, who has obesity. So yeah, those are my thoughts about that.
Okay. So then I'll round it out with a question for Michael. So as a clinician, and as you think about the limitations of BMI, how do we broach this conversation with patients about its continued use or lack thereof in their care?
Yeah, no, that's a great question. I think once again, it's having that shared learning. Many of our patients don't even know where BMI came from. They don't know, was it designed for clinical care? They don't know what it indicates. They just know that's a number that they see every time they come into the clinic. And so it's really explaining, why do we calculate it? Why we use it as a screening tool, but why it's not the end all be all, and it's just the beginning of the conversation. And so that allows them to expand their knowledge about a condition that they're living with, but also in their goal setting and looking at their progress. So we're not treating so that your BMI is 25. We're treating for XYZ. It could be comorbid conditions that we're trying to do risk factor reduction. It could be something else. It could be physical forces. It could be energy level. It could be, just meeting someone's personal goal. And that's what's most important.
Very good. Let me just take a look at the room here. Burning question in the back. Jamie.
So thanks to everyone for nice summaries and comments and provocative thoughts. So I have a question, and maybe several can respond, but to take up Bren's idea around the weight surveillance that you talked about. Some people certainly really just dislike it. My biggest challenge in that space is really sort of separating the number from the actions and the behaviors of providers who stigmatize people. And I think that stigma and bias might happen independent of knowing that individual's weight. Because often that starts when they walk into or present to a healthcare setting, weight unknown. So one of the challenges I have as a clinician is really trying to help desensitize, if you will, that number and de-emphasize it to the point of it's a vital sign like your blood pressure. Like I would want to know your blood pressure, or I want to know what your blood glucose is, and I want to bring it to that level. So I have a difficult time trying to understand how to destigmatize that without engaging people in that conversation. So I'd love to hear discussion around that.
Well, thank you for that question. This is my disclosure. I am not a clinician. So I turn this back. You're a clinician, and the other folks in the room are clinicians, and you're dealing with this every day. But certainly what I've learned from clinicians, and especially working in the eating disorders community, is that can be a non-starter. And everybody gets weighed practically the second they come into any kind of medical center for any condition. That's something that doesn't need to happen, and it's keeping people away from the medical center. There was the suggestion from the physician from this area who was saying, well, I just don't start with that. I wait till I get to know the patient more. We have some rapport. I know what their experiences are around eating disorders or weight stigma or discrimination, how loaded that might be for them. And then we take it from there. And that's what I would offer back, is that it's not going to be the same answer, the same practice for every single patient when you know that there's a subset who are not even coming through your office door because they don't want to be weighed. They don't want to have that conversation, but they're not able to then get the preventive care that they could get if they would trust you enough or trust any clinician enough to feel like they're going to be respected independent of whatever that number on a scale may be.
I think one of the challenges for many patients in these settings is they don't see the necessity for it in every visit. Or are you going to be offering me solutions? Are you going to be treating me? Are you going to have a conversation with me? Or is this just a number that is going to say, oh, and by the way, on the way out the door, you need to lose a little weight? I think that is the experience that many patients are running into. Of course, in a weight management center that we work in, that's not the case. We know why they're coming. So a patient coming to me usually does not have an issue with being weighed because they want to know where they are and they want to be able to track their progress. But what the challenge they run into is when they go into every clinical setting and that's being presented to them and there's no solutions. I think that's a challenge for us as a healthcare industry. There's also learning that we have to do. Again, many times we come together, no one has to convince anyone here that obesity is a disease process that can be treated, that has a very complex. There's still a large percentage of healthcare providers that believe it's a moral failing and they don't offer solutions that are effective. And so I think there's a lot more work to be done from the provider side. If we're going to be measuring something, we have to have a plan to address it. And if we're not going to address it, then we have to ask ourselves, should we be measuring it in this encounter?
Very good. I noticed there are a couple more questions on the chat, but they all sort of follow this line of thinking about how do we start the conversation? And as it turns out, our workshop series, the next one planned, will be in fact about communications around this topic. So I think I'm going to stop here because we're a little bit over 3 o'clock, and I would like to thank the panel for this last section.